Hello, this is John Kanellopoulos, clinical professor of NYU Medical School in New York, and eye surgeon here at the LaserVision Institute in Athens, Greece. It's my pleasure to try and explain to you how we've been using clinically the traditional OCT device. This is the OptiView device, the Avanti, latest model by OptiView. We've used it for many years as a device for macular diagnoses. And over the last 2 years, not only to define cornea on surgery. Okay, so I omitted to mention that this is a very simple exam for the patient. It's non-contact, it takes just a few seconds. We get thousands of cross-sections of the cornea, so the accuracy is much higher than the high-frequency ultrasound we had studied in the past that requires a water bath for the patient's cornea. And you can see here, this is for instance a pre-LASIK evaluation on a young lady. We were getting confirmation of our Seinflug pachymetry measurements. She's over 580 microns at the thinnest part of the cornea. We also pay a lot of attention where in relation to the center of the cornea the thinnest part of the cornea is. We think that this is important in diagnosis of keratoconus. And now we're going to epithelium. This is not perfect epithelium. You can tell it's a lady from the slight irregularities within it, but it is relatively normal. We're at 52 microns, which is the normal epithelium as we had defined in our publication last year in the Journal of Cornea, looking at the very large cohort of normal patients. We're going to go on and see a dry eye patient. We're seeing here one of our signature LASIK extra cases. You can see the hyper-reflectivity within the LASIK flap from the prophylactic cross-linking. This was a very high myope. But besides that, we've had great help from OptiView in establishing cornea epithelial mapping besides the cornea pachymetry mapping, which is obviously far more accurate than Seinflug imaging or ultrasound assessment of the pachymetry. So we're having here a new entity, in my opinion, in refractive surgery and in general dry eye patients and evaluation of cataract patients before and after their surgery. What we're seeing here is obviously the area ablated from this LASIK, myopic LASIK extra patient. We're also seeing here a little bit of post-LASIK dry eye. And this is where this extremely elegant device of giving us qualitative and quantitative mapping of the cornea epithelium can help us monitor the natural improvement of the dry eye or the potential intervention that we will employ in a specific patient. For instance, this young lady was dry for over a month, and we employed plugs, topical cyclosporin, along with lid hygiene, in her subsequent scans there was dramatic improvement besides her improvement in visual acuity and her own personal subjective assessment. So I think we're reaching an era, if you may, that we will have, besides our standard clinical evaluation and the more rogue testing such as tear breakup time and Schirmer testing, a more elegant and more specific way to establish a diagnosis of dry eye, and we've published this recently in the Journal of Cornea, being able to evaluate dry eye through a refractive procedure. And what we're studying and we're trying to make sense, and we think we have made sense, is how these epithelial irregularities may affect refraction. One has to wonder if the epithelial hypertrophy, edema, whatever the cause of this thickening measured by the OCT device, how it may affect placido disc topography, how it may affect standard Seinflug imaging of the cornea, and overall how it may affect the quality of vision of this patient. These data and these clinical pictures are quite compelling to ignore, and we're trying to make sense of this along with the subjective and refractive performance of post-refractive surgery and post-cataract surgery patients, and we think we can make a lot of sense out of this. It is a clinical tool we use in every patient that we evaluate, regardless of diagnosis and regardless of age. And we think once we go from 6mm to 9mm, we'll have a far more better algorithm to make a thin net and being able to objectively screen for dry eye, screen for corneal irregularities that may interfere with refraction, either if that's in the refractive surgery population we're evaluating or the older cataract surgery population. So as I promised you, here we're looking at typical keratoconus, mild keratoconus patient. With the cross-section of the OCT, we can see the degradation of bone lens membrane, and this is where we feel that sign fluke may be off, placido may be off due to it not being very accurate in the center. So the Cassini, multispot, and the OCT may give us a better view looking at the center. The thinnest part of the cornea is off the center. Now looking at keratoconic corneas at the epithelial maps, we think we're seeing a dry eye upside down, meaning as has been described previously, the upper part of the cornea, the thicker part of the cornea, is trying to compensate for the protruding part of the cornea by thickening the epithelium, and the epithelium over the protruding area of the cornea, the actual slopes of the cone and the peak of the cone is quite thinned. The findings that we've published on this are not as extreme as the ones seen in the literature with high frequency ultrasound, but we have to appreciate that these are different modalities. This has an air interface, the high frequency ultrasound has a water interface, and we have theorized that even in corneas that are not as ectatic, the overall increased epithelial thickness may depict a biomechanically unstable cornea. It may be a reaction of the cornea epithelium to more increased oscillation of the cornea and epithelial injury. So very interesting for our work, our signature Athens protocol combined topography guided PRK normalization with high fluence cross-linking. You can see that the pachymetry maps show that this patient has a cone just off the center, which we cannot see anymore in the epithelial maps. The epithelial maps are subnormal, about 40 microns epithelial thickness in these corneas, reinforcing the data we had seen with high frequency ultrasound that cross-link corneas have thinner than average epithelium and much more normal, despite that the cornea thickness is different and that this patient still has some keratoconus. So this is functionally showing the effect that cross-linking with the Athens protocol has on these corneas, and we can of course see the line that we have described previously that shows the depth of cross-linking, the hyperreflectivity, and the cross-section. I hope you found this presentation interesting. This is John Kalopoulos signing out from Athens. Thank you.